Hello. As Savannah said, my name's Lauren Shaefer. I am an assistant scientist at the Sanford Center for Biobehavioral Research down in Fargo, where I spend most of my time conducting studies aimed at trying to understand some of the risk and maintenance factors that contribute to eating disorders. In addition, I'm a licensed clinical psychologist, so when I'm not conducting research, I'm spending my time over at our clinical entity, the Sanford Eating Disorders and Weight Management Center, where I'm actually delivering therapy to folks who are currently struggling with eating disorders. So this is a really important topic to me. I am so grateful to have received this administrative supplement from the TRANSCEND grant, and I'll spend the next 10 minutes or so, Mark, telling you a little bit about this project. I'm getting to the age where it is getting harder to see that slide, so apologies. Sometimes I may turn behind me. But this project is organized around trying to identify the key reward and maintenance, punishment processes that might contribute to an eating disorder called anorexia nervosa. So what is anorexia? Anorexia nervosa, as you'll see it on my slides, often AN, is a very serious psychiatric disorder that is characterized by extreme dietary restriction, as well as extreme use of other kinds of weight control behaviors, those things like excessive, really compulsive exercise that ultimately drive patients' weights down to very dangerously low levels. Because of that low weight, because of those extreme weight loss behaviors, our patients with anorexia are at very high risk for experiencing a range of very serious physical health consequences. So things like osteoporosis, heart problems, kidney problems that ultimately can be life-threatening for these patients. In fact, anorexia is among the deadliest of all the psychiatric disorders, second only to opioid use disorder, due to these pronounced physical or medical consequences, as well as high rates of suicide that we see in this patient population. Currently, there are no empirically supported treatments for patients with anorexia nervosa, at least adult patients with anorexia nervosa, leading to roughly a third of these patients developing a chronic, often lifelong variant of this illness, which can be devastating for these patients' lives. So, in the absence of effective interventions, there is a clear need, at least as far as I'm concerned, for more research to try to clarify the key factors that maintain anorexia nervosa so that we can develop more effective interventions for this disease. Now, notably, reward and punishment processes are thought to play a role in all human behavior. So if you think about your own lives, you might notice that the behaviors that for you were rewarded more consistently, more strongly in the past, are likely the behaviors that you pursue more consistently in the future. Whereas the behaviors that maybe were punished for you most strongly in the past are gonna be behaviors that you more strongly avoid moving forward. Our clinical observation of patients with anorexia nervosa suggests that this behavior of anorexia, this extreme dietary restriction, these other weight control behaviors, are experienced as very highly rewarding to these individuals, while food consumption is experienced as very highly aversive or punishing. Indeed, some folks have theorized that folks with anorexia may experience greater reward from these weight loss behaviors than they do from other typically sort of rewarding behaviors like spending time with friends, and they may experience greater distress associated with eating than they would from other typically sort of punishing outcomes, like having to experience all of the medical consequences that come along with these behaviors. Theoretically, that experience of having received prior rewards from one's anorexia behavior or experiencing prior punishments from one's eating behavior would be expected to contribute to disorder persistence or the maintenance of those behaviors through a process of positive and negative reinforcement. But importantly, very limited research has actually directly tested that hypothesis, which has hampered our ability to identify the key mechanisms that may maintain this disorder and potentially serve as modifiable treatment targets for this patient population. So, in order to try to comprehensively assess the role of reward and punishment processes in maintaining anorexia nervosa, this study has three aims or three goals. First, we want to try to examine neural responding to reward and punishment experiences among patients with anorexia nervosa. We want to evaluate whether those reward and punishment experiences predict later symptoms of anorexia, now in the real world, in patients' real lives outside of the lab. And we also want to explore patients' perspectives of the role that reward and punishment processes might play in maintaining their symptoms. So to address or to achieve that first goal, examining neural responding to reward and punishment among folks with anorexia nervosa, we're going to have 40 women with anorexia who will complete a computer-based incentive delay task while their brain activity is being recorded using electroencephalography or EEG. Let me tell you a little bit about this task. So in an incentive delay task, participants are told you're going to have the opportunity in this task to win and lose rewards. In particular, in our study, participants have an opportunity to win or lose money in some trials, or win or lose exercise in other trials. So they're told, sit down in front of this computer screen. All I want you to do is when you see an image appear on the screen, I want you to press this button as fast as you can. If you press that button fast enough, you're going to get a reward. If you're too slow, however, you're going to lose a reward. So the task itself is very simple. Because we're measuring brain activity throughout this task, it allows us to examine neural activity in response to winning or losing different kinds of rewards, monetary rewards and exercise rewards. In particular, we're going to be looking at something called the reward positivity or the RUP, which we heard a little bit about earlier. This is an EEG signal that occurs about 250 milliseconds after the participants receive that rewarding feedback or that punishing feedback. And simply put, a strong RUP or a strong reward positivity would suggest greater sensitivity to that reward or punishment, while a weaker RUP is going to suggest weaker sensitivity to that reward or punishment. For our study, we're hypothesizing that patients with anorexia will demonstrate greater neural responsivity or a stronger RUP to exercise rewards and punishments relative to those monetary rewards and punishments. So in other words, we think the brains of folks with anorexia nervosa are going to be very excited to win exercise, very sad to lose exercise, but less impacted by winning or losing money. To address our second goal, evaluating whether these reward and punishment experiences predict later symptoms of anorexia nervosa in the real world, the same sample is going to complete an ecological momentary assessment or EMA protocol to evaluate the relationship between these reward and punishment experiences and their anorexia behavior in the real world. Again, we're moving from lab to real life. So what is EMA? An ecological momentary assessment protocol involves repeatedly assessing your participants' either current, right now, or very recent, in the last couple of hours, experiences multiple times per day using something like your smartphone or a very small electronic tablet that your participants can carry with them as they're sort of going about their day-to-day lives, carry with them for days in a row. And a key sort of benefit of this approach is that it allows researchers to be able to examine the temporal, meaning time-based relationships between variables that they're interested in the real world. In our study, participants are going to be recording their behaviors of anorexia nervosa, these symptoms of anorexia nervosa, as well as their eating episodes, and how pleasant or aversive, how rewarding or punishing they found those experiences to be several times per day for 14 days in a row. We have two key hypotheses for this sort of portion of our study. First, we hypothesize that when our participants experience more reward from their anorexia behavior on one day of the protocol, it's going to predict a greater likelihood that they'll engage in that behavior on the next day of the protocol. Second, we hypothesize that when our participants experience more punishment from their eating on one day of the protocol, it's going to predict a greater likelihood that they will restrict their eating on the following day of the protocol. Finally, to achieve our third goal of the study, exploring patients' perspectives of the role that reward and punishment processes might play in maintaining their symptoms of anorexia nervosa, the same sample will complete now a qualitative interview that has been designed to elicit their experiences of reward and punishment related to their symptoms. And what we hope to hear about in these interviews are the kinds of rewards that patients have experienced from their symptoms of anorexia nervosa, perhaps including praise that they received from other folks when they started to lose weight or when they started to engage in this more excessive form of exercise. Maybe we'll hear about the degree of self-confidence that they gained when they started to engage in these behaviors, or maybe we'll hear about the way that these behaviors help them to regulate unpleasant, aversive emotional states. We also hope that we'll hear about the kinds of punishments that people are using this behavior to avoid. So maybe we'll hear that they're using the behavior to avoid appearance or weight-based comments or teasing, or maybe they're using the behavior to avoid extreme emotional distress that they'd rather not experience. Ultimately, we hope that by using this comprehensive assessment approach, it will help us to clarify the influence of reward and punishment processes in maintaining these symptoms, which ultimately could inform our treatment approaches. So for example, if we find that punishment or fear-based processes are really central to maintaining the symptoms of anorexia nervosa, then we could use exposure techniques to expose our patients to these feared outcomes or stimuli in a very safe, very controlled environment in order to reduce their anxiety or their fear response to those outcomes or those stimuli over time. On the other hand, if we find that reward-based processes are really actually most central to the symptoms of anorexia nervosa, then we could have our clinicians help patients to identify and then practice alternative, meaning healthier, behaviors that are aimed at achieving similar rewards. So what's a more adaptive behavior that you could use to enhance your sense of self-confidence or to help regulate those unpleasant emotional states? Of course, I am not doing this work all by myself. I have a number of really wonderful colleagues, some of whom are here in the room. So Dr. Glenn Forrester, Dr. Leslie Lamb, Dr. Steve Wunderlich, and Dr. Lee Bao, who's my mentor through the TRANSCEND project, have all been wonderful collaborators and great support on this project. Of course, I again want to thank folks involved in the TRANSCEND grant. Thank you for all of your support. It's lovely to be a part of this grant. Happy to take questions. Or not, which is also fine.
Great talk. That was really interesting. So thinking down the line, you're talking about incorporating this into therapeutic interventions. Do you envision a point where the same way that you're collecting this information can actually be part of the therapeutic process? So like if they answer in a certain way that triggers the app to say, oh, hey, you're in danger of doing this, or provide feedback and more immediate counseling? And if so, do you view a role of AI in that interplay, an AI chat therapy bot type of thing?
Yep, great question. Thank you, Lee. I don't know if you've talked with Steve, but you have perfectly set up our next grant application, actually. So yes, people are really interested in, so I've been talking to you about ecological momentary assessment, where we're just collecting data from folks, learning about them as their day goes on, but folks are interested in translating that into ecological momentary interventions. I can see that you just said you're experiencing high levels of negative affect. I know that that puts you at risk for a binge eating episode or restricting your intake, and so I'm going to push an intervention to your phone that hopefully will nudge that symptom in the right direction. So far, our EMIs, our ecological momentary interventions, at least in the eating disorders, but I think this might be true kind of across the board for a lot of psychological disorders, have not been as effective as we perhaps hoped they would be. In walks machine learning or artificial intelligence. So one of the hopes of this advancement is that it might help us to learn a little bit more quickly or efficiently or effectively from the data that participants are providing. And identify improved algorithms for really understanding what it is that sort of tips the scale from being okay in one moment to being prepared to use an eating disorder behavior in the next moment. So absolutely, I think that's the logical next step for this kind of work.
That was a great talk and a great line of work. I was wondering along the lines of Lee's question, if you might be able to use some real world data, like collected from a person's home, like things like how many times a refrigerator opened and closed,
Yeah.
what kind of social interactions they have with dyadic partners who might support them in their moments of weakness, or even physiologic measures like from personal devices like smartwatches that are recording heart rate when somebody's throwing up, for example, or,
Yep.
or a galvanic skin response, or you name it.
Yep. Another brilliant sort of area to move forward. So right now we've been talking about sort of non-passive forms of data collection. It requires the participant to say, yes, I'll engage with my phone and I'll tell you what I'm doing right now. But more ideal perhaps is to be able to collect data passively. So my watch is maybe sending information back to some machine learning algorithm that can ping me when I am up to no good. I think that is another wonderful way of moving forward. We have some folks in our building who are using actigraphy right now, who are particularly interested in sleep, but of course you can measure other things. But I think wearables are really of interest. I should mention we have another individual in the lab who's using CGM, continuous glucose monitors, to monitor blood sugar and see if that could be a potential sort of signal for indicating risk for an eating disorder behavior.
Lauren, great talk.
Thank you.
Great talk and a really important topic. I have a sort of general question, and I'm wondering, do you believe that anorexia, unlike some other psychiatric disorders, is preferentially maintained by reward and benefit? I mean, if you were up there and you were talking about schizophrenia or some delusional syndrome like Capgras syndrome, where you believe that your loved ones have been replaced by lookalikes, I would be very dubious that those things are maintained by reward and punishment. Do you think, for example, that this would be applicable to, say, other psychiatric disorders?
Yes, Dr. Schwartz, and in fact, we've stolen the idea, to be quite honest. Eating disorders is usually sort of last in line in coming up with new sort of theories often. Often we're looking at other larger fields. We're a small field. So we're looking at depression research or anxiety research, or in this case, substance use research, to try to glean insights from some of the things that they're identifying and see if that fits with our patient population. So a lot of this thinking, frankly, comes from the substance use literature. So I wish I could say it was some brilliant idea we had come up with, but we stole it.
It's yours now. And you're doing
Thank
a great
you.
job with
Thank you,
it.
sir.
All right, let's give another round of applause for Dr. Shaefer.